Welcome to the RadOnc Smart Review Head and Neck Cancer Series.
Today we are covering episode 24B, the Nasopharynx Planning Workshop, specifically focusing on skull base abutment cases.
Welcome back. We've spent the last few sessions really building the foundation. We've hit the anatomy, we've talked staging, gone deep into EBV biology, systemic therapies.
Little building blocks.
Exactly. But today, this feels different. It feels like we are, walking out of the classroom and actually sitting down at the console.
That is the perfect way to put it. This is where the rubber meets the road. I mean, it is one thing to know the staging of a tumor. It is an entirely different beast to be staring at a CT slice where that tumor is millimeters away from the brainstem, and you have to decide, okay, where does the dose go?
And that really is the mission for this session. We are at the Nasopharynx Planning Workstation because these decisions you're making in the next, say, 40 minutes or so, they're not just technical.
No, not at all.
They really determine whether a patient lives with acceptable function or if they suffer what we'd call a catastrophic late toxicity.
It sounds dramatic to say it like that, but it is the absolute reality. And before we even touch a mouse, before we even look at a single contour, we have to establish the stakes. The why.
The why.
Why do we obsess over every single millimeter at the skull base?
And to answer that why, we really have to look at the data. I'm thinking of the TROG-0202 trial.
Yes.
It's just a fascinating piece of research because it wasn't just about drugs. It was like holding a mirror up to the quality of the radiation planning itself.
That's it. It was a trial looking at concurrent chemoradiation for head and neck cancer. And when they went back and actually analyzed the quality of the plans, the results were, frankly, eye-opening.
They really were.
They found that protocol deviations, I mean, let's be honest, mistakes in how the targets and the organs at risk, the OARs, were drawn, those mistakes were tied to significantly worse outcomes.
The numbers are just staggering. I want to make sure everyone listening really hears this. We are not talking about a 1 or 2% difference here.
No, not even close. For patients with major plan deficiencies, the 2-year overall survival dropped from 70%.
Which is where it should be.
Right. In the good plans, all the way down to 50%.
A 20% absolute survival difference. You could find the best chemotherapy drug in the world, and it probably wouldn't give you a 20% bump like that.
Exactly right. And it wasn't just survival. The 2-year freedom from local regional failure, so the cancer coming back right where we treated it, that dropped from 78% to 54%.
So the data is basically screaming at us that bad planning is more harmful than skipping the chemo.
It is. The impact of poor RT planning was actually greater than the benefit of adding concurrent chemotherapy in the first place.
That is just a massive statement. It means plan quality is not cosmetic. It's not about making the color wash on the screen look pretty.
No, it is survival.
It is survival.
And with NPC, nasopharyngeal carcinoma, this is just amplified because you have those skull base OARS, the optic nerves, the brainstem just sitting there millimeters from your target. The decisions at the workstation are the exam.
So, our mission today is to learn how to defend the trade-offs.
Yeah.
Because there will be trade-offs. You have to know what to do when your target coverage and a priority 1 OAR collide.
And you have to know when to escalate versus when you just, normalize a violation, which you should never do.
Right. Let's get to the workstation. Section 1, the dose prioritization framework.
Right. Before a single case, before a single contour, we need a hierarchy. We need a set of rules. When target coverage and organ safety conflict, who wins?
It's like a triage system for dose.
Exactly. And we rely on international dose prioritization guidance to set this up. We categorize all the structures into priorities. And at the very, very top is priority 1. We call this inviolate.
Inviolate. I love that word. It sounds medieval. It means unbroken, unharmed. So these structures define the absolute planning boundary. We just do not cross this line.
Correct.
So which structures are we talking about here?
We're talking about the big 4, the optic nerves, the optic chiasm, the brainstem, and the spinal cord.
The why is pretty intuitive, but let's spell it out. Why are these the ones we just can't touch?
Because an injury here is catastrophic. It leads to a total loss of quality of life. We are talking about blindness. We're talking about paralysis. We're talking about death.
So the rule is simple.
The rule is simple. Violations are not accepted. If your plan violates a priority 1 constraint, you do not click approve, you stop, and you trigger an escalation.
Okay, so that's the do not cross line. What's next? Priority 2. What's in that bucket?
Priority 2 is where the nuance lives. This includes your target volumes and, very importantly, the temporal lobes.
Oh.
Target coverage matters. I mean, we just saw the TRG data. It matters enormously. But, and this is the key, not at the cost of a priority 1 injury. We have to cover the tumor, yes, but not if it means blinding the patient.
So if push comes to shove, priority 1 beats priority 2.
Every single time. No exceptions.
And then we've got priority 3 and 4.
Right. These are the functional structures. The cochlea for hearing, the parotids for saliva, the mandible, larynx, the constrictor muscles for swallowing.
The things that make life worth living after the cure.
Exactly. We optimize these as much as we possibly can. Dry mouth and swallowing problems are terrible.
Yeah.
But they don't define the hard boundaries like priority 1 does. We can accept some higher dose here if it is absolutely necessary to cure the cancer.
Okay, let's go back to that inviolate rule. I want to play out a scenario. I'm at the workstation, I've run my optimizer, and boom, my plan violates the optic pathway constraint, or the brainstem. And I can't fix it. The tumor is just too close. What do? You said escalation.
Right. You've got 3 main levers you can pull. The first one is induction chemotherapy.
Okay, explain the logic on that one.
So if this is a patient presenting up front, they haven't been treated yet, and the tumor is physically touching the brainstem or the chiasm, we consider induction with gemcitabine and cisplatin.
And the goal there isn't just systemic.
No, the goal is mechanical. We want to shrink the tumor. We want to physically pull it back from that ledge to create a margin, a little bit of breathing room, before we lock in the final radiation plan.
You're literally buying real estate.
You're buying real estate, exactly. Now, what if you're already halfway through treatment? That brings us to option 2, adaptive replanning.
And how does that work?
So let's say the initial plan was really tight, the constraints were borderline. You can plan ahead to repeat the CT simulation, ideally with an MRI fusion, around week 4.
At about 40 gray.
Yeah, about 40 gray-ins. NPC is usually very responsive to radiation. So by week 4, a lot of the time, the tumor has melted away significantly. If that regression has created some separation, you replan right there for the final boost.
That's smart. You're reacting to the patient's own anatomy in real time. And option 3?
Option 3 is a referral for proton therapy.
Protons. The expensive tool in the shed, but sometimes a necessary one.
In very select cases, yes, where standard IMRT just physically cannot achieve a safe plan because of the physics, the exit dose. A proton therapy consult may be the right move. Protons have that Bragg peak. They stop.
Right. They don't exit through the brainstem like photons do.
Exactly.
So if I'm in an oral board, or I'm just trying to explain this to a colleague, what's the board-sayable principle? What's the one sentence I need to have locked and loaded?
The sentence is, if my plan violates optic pathway or brainstem constraints, I stop and escalate, rather than normalize a priority 1 violation.
Never normalize. That's the mantra. Because normalizing just sounds like clicking a button to make a warning go away. But what you're really doing is accepting a risk of blindness.
You are. Do not just change the numbers to make the plan pass. Change the strategy.
Okay, one last thing here before we move on.
Yeah.
PRV is planning organ at risk volumes. What's the standard?
We use a minimum of a 2 millimeter PRV. This is basically an institutional practice to account for setup variation. The patient breathes, they swallow, they might shift a tiny bit in the mask.
Is 2 millimeters universal?
It's a very common standard. Some centers might use a differential PRV, maybe 1 millimeter up at the rigid skull base and 3 millimeters down in the more mobile lower neck. But 2 millimeters is a very safe, very standard margin.
Okay, let's move to section 2. We have to talk about the boogeyman of NPC treatment. We have to talk about temporal lobe injury.
This is the signature late effect. If you cure the cancer but you fry the temporal lobes, you have not done that patient any favors.
So we need the numbers. We need the red line. When I'm looking at a DVH, a dose volume histogram, what am I looking for?
The practical checkpoint you absolutely must memorize is D 0.5 cc's of approximately 69 gray.
D 0.5 cc. So the dose to the hottest half a cubic centimeter of the temporal lobe.
Correct. When you see your D 0.5 cc creep over 69 gray, you have to stop. You have to ask yourself, is this truly necessary or can I re-optimize this plan?
And D1cc is also important.
Yes, D1cc is a leading predictor of injury in almost every multivariate analysis. We track it on every single NPC plan we do.
Let's talk about the reality of the risk, though, because sometimes you just can't avoid those numbers. For a T4 skull base abutment case, even with perfect planning, The risk isn't zero.
No, and we have to be completely honest about this. For those T4 cases, the 5-year risk of injury is approximately 13%, even with optimal planning.
13%, that is not a small number.
It is not. You are accepting a low double-digit risk. But you have to ask why. And the reason is that the alternative is underdosing the tumor at the skull base, which leads to recurrence. And a recurrence there is almost always fatal.
So it's a calculated and counseled gamble. We use an if/then framework for this. Can you walk us through that?
Sure. So if your metrics are elevated, let's say that D 0.5 cc is over 69 gray, and it is not a skull base abutment case, then you have to reoptimize. You're just leaving dose on the table unnecessarily.
You're being lazy.
You're being lazy with your plan. But if it is a T4 abutment and you've maxed out all your trade-offs, you've tried everything,
Then you accept it.
then you accept it. But, and this is the most important part, you accept it with explicit counseling.
You have to tell the patient what that risk is.
You absolutely have to.
What about the timing? When does this injury, temporal lobe necrosis, actually show up?
For a primary treatment, the first time around, the median onset is about 3 to 4 years later.
Wow. So they finish treatment, they feel fine, they think they're in the clear, and then years down the road.
Exactly. But for reirradiation, if we have to go back in, the timeline is much, much faster. It's about 15 months.
So for that counseling conversation, for that T4 case, how do you phrase it? What do you say?
You have to explicitly mention that the risk is in the low double digits. You might say something like, for this advanced tumor, the risk of an injury to the temporal lobe of the brain can be in the low double digits at 5 years. I'm doing everything possible to minimize this, but we have to accept this risk to cure the cancer.
That's a good script. It's direct. It's honest. Okay, let's apply this. Section 3, planning case 1. This is our baseline, the clean plan.
Okay, let's set the scene. A 52-year-old woman, she's a T2N1M0, non-keratinizing, undifferentiated type. And the key here is no skull base invasion, no brainstem proximity.
This is the fastball right down the middle. Walk us through the sim details because these matter for boards and for real life.
Absolutely. The patient is supine. We want an extended neck with the shoulders pulled down, pulled inferiorly.
Why pull the shoulders down?
You have to get them out of the way of the beams. If the shoulders are hunched up, your lateral beams have to go through all that bone and muscle to get to the neck nodes. It just messes up your dosimetry.
So what do you use to hold them there?
We use a long thermoplastic mask that extends all the way to the shoulders, locking them in place. And we use a tongue-depressing bite block.
Oh, the tongue depressor is so key.
It is. It pushes the tongue down and forward, sparing it from that high-dose bath that's treating the nasopharynx. It saves their taste. It saves them from just horrible mucositis. And, of course, IV contrast to see the nodes.
Okay, let's talk target volumes. Where are we drawing the lines?
All right, first up is the GTVP. That's the gross tumor volume primary. It's the mass you can see in the nasopharynx plus any obvious parapharyngeal extension. Then you have your CTV high. This is your high dose volume, getting 70 gray. It's the GTV plus a margin, usually 3 millimeters, for microscopic disease.
And then the prophylactic volumes, the intermediate and low risk areas.
Right. CTV intermediate gets 59.4 gray. This covers the whole nasopharynx, posterior nose, clivus, parapharyngeal space, retropharyngeal nodes, and the bilateral upper neck.
That's a lot of anatomy and low risk.
CTV low is 54 gray, and that covers the lower neck, levels 4 and 5B.
So for this clean case, what are our OAR goals?
Brainstem and the optic structures, we want the max dose, Dmax, under 54 gray. For the temporal lobes, D 0.5 cc under 69 gray. And for the spinal cord, Dmax under 45 gray.
So what's the big teaching point here for a clean case like this?
This is a no excuses plan. That's what you need to remember. Because there's no conflict, there's no abutment, your PTVV95 has to be at least 95%.
Meaning 95% of your target gets 95% of the dose.
Correct. If you can't hit that coverage on an easy case while meeting all the OAR constraints, your technique is wrong. You need to go back, fix your beams, fix your objectives. Do not accept a subpar plan when you don't have to.
Okay, that was the warm-up. Let's turn up the heat. Section 4, planning case 2. This is the T4 brainstem abutment.
Here's the conflict. 58-year-old man, T4N2. The tumor is physically abutting the brainstem. The margin between them is only 2 or 3 millimeters.
Okay, so if we do our standard PTV expansion, that 3 millimeter margin we just talked about, our target is now overlapping the brainstem. We physically cannot get 95% coverage without violating our priority 1 constraint.
Exactly. This is the dilemma. Physics is fighting biology, and we need a decision tree.
So step 1.
Step 1 is to consider induction chemotherapy, just like we talked about. Can we buy some real estate? Can we shrink this tumor away from the brainstem before we even turn the machine on?
Makes sense. But let's say the patient declines, or we decide to go straight to chemoradiation. What's step 2?
Step 2. We accept intentional PTV undercoverage at that interface.
Intentional undercoverage. It sounds so wrong.
I know it does, but it's the right choice. We maintain full dose to the GTV, the gross tumor. You have to kill the cancer, you can see. But we shave the PTV margin right where it touches the brainstem. We carve it back.
So the microscopic margin gets a little less dose, but the brainstem is kept safe.
That's the trade-off.
And step 3 is documentation. You can't just do this in a vacuum.
Oh, this is critical. You must write it in the chart explicitly. PTVV 95 equals 91% undercoverage intentionally accepted per dose prioritization guidance to spare the brainstem.
You're showing your work. You're showing it was a conscious choice, not a mistake.
You're defending the trade-off. And finally, step 4. This is your safety net.
Which is?
Build in adaptive replanning. You treat with this tight plan, but you book them for a repeat CT SIM and MRI around week 4 at about 40 gray. If that tumor has pulled back, you might be able to get that coverage back for the end of treatment.
In these T4 cases, you often see cavernous sinus abutment too. What's the reality for the temporal lobes in that situation?
The reality is the cavernous sinus sits right under the medial temporal lobe. It's just geometry. You cannot treat one without dosing the other. So your temporal lobe D 0.5 cc is probably going to be in that 68 to 72 gray range.
And that's acceptable.
It is acceptable if it's anatomically necessary.
Any quick planning tips? How do you actually tell the computer to do this carve-out?
Yes, a great trick is to create a new structure in your planning system. Call it brainstem PRV minus PTP. You use that new structure to drive the optimization. It tells the software exactly where the no-go zone is.
Great tip. Okay, section 5. Planning case 3. Re-irradiation. This has to be the highest stakes scenario of all.
This is the wild west of planning. The scenario is a 61-year-old man. He's got recurrent NPC 2 years after his first treatment. The tumor is right up against the internal carotid artery, so surgery's off the table.
We have to re-irradiate. We need an evidence anchor here, because this is dangerous territory. What guides our approach?
We look to the phase 3 data that supports hyperfractionated IMRT. There was a trial that compared 65 gray in 54 fractions. That's twice a day, BID, versus a more standard 60 gray in 27 fractions once a day.
And what was the outcome?
The hyperfractionation, the twice daily treatment, it significantly improved 3-year overall survival. It was about 73% versus 54%.
That's a big deal.
It is, but even more importantly, it reduced grade 5 events.
Grade 5 means treatment-related death.
Yes, it reduced the rate of fatal bleeds, fatal necrosis, from 8.1% down to 1.6%.
Wow. That is a profound difference. So hyperfractionation is the backbone. It gives normal tissues a little more time to repair.
Exactly. So what are the planning principles for re-irradiation?
GTV only. No elective nodes. We only treat what we can see.
Tight margins. CTV is GTV plus 5 millimeters, but you shrink that down to 0 to 2 millimeters right at the OAR.
Principle 3 is the dose we just talked about.
Yep. Hyperfractionated dose, 1.2 grays per fraction, twice a day, BID.
And principle 4.
Accept undercoverage at those interfaces. Again, priority 1 structures are still inviolate, and you have to remember, they've already seen a full course of radiation. They have a long memory.
Which brings us to principle 5. Know when to say no. You have to think about cumulative tolerance.
Exactly, which means our constraints are much, much tighter than for a primary case. For the brainstem and optics, D 1% has to be less than 50 gray. For the temporal lobe, D 1% has to be less than or equal to 54 gray. And for the spinal cord PRV, D 1cc under 40 gray.
Let's just do the cumulative math on that. If the temporal lobe's got, say, 68 gray the first time around, and now we're adding another 54.
You're over 120 gray cumulative. The risk of necrosis is not low double digits anymore. It's substantial. It's high.
Which leads to what you've called the hardest conversation. The counseling.
It is the hardest. You have to look a patient in the eye and say, there is a 1 in 3 chance of a significant severe late effect. This could mean brain tissue dying. It could mean a carotid blowout. It could mean severe fibrosis. But without this treatment, this cancer will progress and it will take your life. It is a true balance of very high risk versus certain progression.
That is heavy, but it's the job. Okay, Section 6, proton therapy considerations. When do we pick up the phone and make a referral?
The rationale is all about the Bragg peak. Photons or X-rays go in one side and at the other. Protons go in, dump their dose, and just stop.
So you get a much sharper dose fall off.
Exactly, which for NPC specifically reduces that V50 to the temporal lobes and the integral or total dose to the brainstem.
So what are the key referral scenarios?
Scenario 1 is that T4 case with cavernous sinus or brainstem abutment, but specifically when photons just fail to give you a safe plan. If you're looking at your IMRT plan and you just cannot meet the brainstem constraint without torpedoing your coverage, that's when you think about protons.
Okay.
Scenario 2 is reirradiation. Minimizing that extra, unnecessary integral dose to tissue that's already been zapped once can be a huge game changer for toxicity. And scenario 3 is our pediatric or AYA, adolescent and young adult patients. We want to reduce that low-dose bath to the rest of their body to lower the risk of a second cancer 20 years from now.
So for the boards, we need a balanced take. We don't want to sound like a proton salesman, but we can't ignore it either.
Right. The board statement would be something like, protons offer clear dosimetric advantages, but cost and access have to be weighed against IMRT, which still cures the vast majority of NTC. I would consider a proton referral for cases where I find photon constraints are unachievable.
Perfect. Section 7, synthesis and traps. Let's quickly recap the whole planning algorithm.
It's a flow. First, assess the anatomy. Is it clean or is there a conflict? Then, apply the hierarchy. Priority 1 is inviolate. Escalate if you need to. Induction, adaptive, protons, document your trade-offs, and always, always use adaptive planning as your safety valve.
Okay, let's hit the oral board traps, the things examiners love to throw at you. Trap number 1, normalizing a priority 1 violation just to get coverage.
The examiner shows you a plan. The brainstem is getting 58 gray, and they say, but look, the PTV coverage is 99%. Isn't that a great plan? The right answer is no, I stop. I would re-optimize to reduce that brainstem dose below 54 gray, even if that means accepting PTV under coverage. I would never normalize a priority 1 violation.
Don't take the bait. All right, trap 2, forgetting about adaptive planning.
Right, you have a tight plan, you accept it, and you just blindly treat for 7 weeks. That's the trap. The right answer is, I would proceed with this tight initial plan, but I would trigger a week 4 resimulation and replanning to capitalize on any tumor shrinkage.
And trap number 3, using primary treatment constraints for a reirradiation case.
The examiner asks for your constraints, and you say, oh, for temporal lobes, D 0.5 cc, less than 69 gray. Wrong. The right answer is, no, for reirradiation, I must use the tighter constraints from the hyperfractionation trial. For example, a temporal lobe D, 1% of less than or equal to 54 gray.
Excellent. Section 8, the board blitz. Let's put everyone listening in the hot seat. I'll ask the question, you get the answer. Question 1, you've got a T4 case. Your brainstem D 0.1 cc is 56 gray. That's a violation. But your PTV coverage is great, 97%. What's your action?
Re-optimize. You must reduce the brainstem dose to below 54 gray, even if it means accepting less PTV coverage. Priority 1 is inviolate.
Question 2, a different T4 case, true skull base abutment. Your temporal lobe D 0.5 cc is 71 gray because of the anatomy. How do you counsel a patient?
You counsel them that the risk of late injury is in the low double digits, around 13%. You explain it's necessary to treat the cancer, and then you surveil them closely. You do not abort the treatment.
Last one. Question 3. What is the reirradiation fractionation scheme that is supported by Phase 3 evidence?
That would be 65 gray, delivered in 54 fractions, BID, hyperfractionated IMRT.
This has been an incredibly dense session, but so critical. Let's wrap with the outro and a summary of the big pearls.
Pearl 1, TROG 0202. Remember that plan quality equals survival. Do not cut corners.
Priority 1 OARS, your brainstem, optic nerve, spinal cord, they are absolutely inviolate.
The temporal lobe red line is that D 0.5 cc of about 69 gray, know that number, and Pearl 4. For reirradiation, the hyperfractionation backbone is your standard of care. It's proven to reduce that deadly grade 5 toxicity.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.